Welcome to EASD TV, and now for a treat. I'm absolutely delighted to have with me Roman Hovorka, who is the winner of this year's Novo Nordisk Foundation Prize, a very, very distinguished prize. Roman, it's such a pleasure to have you with us.
Thank you so much, and I'm delighted to be here and then share with you what has been achieved, and also acknowledge all the people and everybody who helped me to get here where I am.
Now let's talk a bit about Roman Hovorka, because of course artificial pancreas is what you're known for. But if I'd gone back to the beginning of your career, you were not a diabetologist, you were a mathematician. So tell me how this has happened to you.
I don't know, but I can share my story. So I graduated in informatics, mathematics at the Charles University in Prague.
And you are a Czech.
I am Czech, indeed. I'm British as well, so I have dual citizenship. And I got my first post in the university hospital. And there were all these doctors, everybody was there, and there was one single guy who was a mathematician, informatician, and they were speaking different languages and different approaches. But over the time, we somehow sort of managed to understand each other. But it was an interesting transformational area, and I was lucky to be in a hospital which was very much research oriented. So I did my basics, all the different things. I learned lots of small things, and I learned that we can work together as well, and they learn as well.
So mathematics is the universal language, of course, but when did the interest in diabetes begin?
I was dropped into a research group which very much work in the diabetes and the university hospital, and even at the time, which was early 1980s, there was actually artificial pancreas available at the time. It was a machine called Biostator. It was the size of a big fridge. It drew about 50 millimeters of blood every 24 hours.
So it's a kind of vampire machine.
It cost about $40,000 or $50,000, and we had it for research purposes. So it was at a start, and I could.
And presumably you just pulled it behind you on a kind of trolley.
Somebody had to push it because you had to be stationary. It was used for research purposes, not for treatment. So it was interesting to see the combination of technology for use for medical purposes at the time. So I think it started there, to be honest.
And at that stage, you were still in. What was then the Czech Republic, or were
Czechoslovakia at the time?
Czechoslovakia at the time. And what made you come over to the UK?
So I was fortunate enough again to get a Welcome Trust traveling fellowship in 1989. So I came for 1 year to UK. I went to the group which. There was one author which published a book about mathematical modeling of physiology, and I said, well, that's the guy I want to go to London. So I went for 1 year and stayed a little bit longer than 1 year.
And the University of Oxford has been your home ever since.
Yeah. I actually started at City University in London, but then I moved to Cambridge.
Cambridge.
I don't know, yeah. Cambridge, I will be.
Cambridge, sorry. There's a big rivalry between Oxford and Cambridge. I couldn't have committed a greater faux pas. Apologies, all those from Cambridge. So you are now in Cambridge. You are a mathematical modeller, and today mathematical modelling is everywhere. But in those days it wasn't quite as common, particularly in medicine, as it is now.
It is absolutely correct that we now living in the intersection of interdisciplinary research between mathematics in various aspects of physiology and clinical science as well. At the time, it was not. About early 2000, there was a paper published by Vandenberg from Belgium about improving glucose control in people in ICU and saving lives. It was tremendous at the time, and we got a research grant from European Commission as well to work on that. And this is actually how I started in the ICU, but also we had another European grant where one company from Switzerland reached to us and basically said we would like to close loop. So it was at the area where it sort of sensor glucose measurements are becoming available slowly, or people think about it, and the idea was, can we combine these concepts of sensing and algorithm and delivery to automate system which was done manually before then?
And you did indeed prove that you could do exactly that.
Yeah, together with the whole community. Again, it was a community achievement, so I take it as a prize for all the work done by us and also others. When we started, people really they were aiming for perfections. And I think aiming for perfection is actually, it was counterproductive, because people were not willing to say, well, maybe we don't need the super perfect system. So people try to do implantable system, which would be perfect, because the way we give insulin is subcutaneously instead of giving to portal vein. But so now we have, and at the time, again, people were saying in 5 years we will have a system, or 10 years, and it never happened. But then it actually happened thanks to funding opportunities, community work, and our contribution as well.
So what was the date or the moment when you thought, actually, this is a real possibility?
I think there were probably 2 or 3 defining moments. One was, we created a focus group of parents with children. You might remember at the time there was the period of genetically modified crops as well. It was.
I do indeed.
Indeed, and we have this fantastic technology, but nobody wanted that.
Yes, I mean, so just to tell our viewers that there was a huge debate in the UK about genetically modified organisms, because Monsanto had come in with a non-squished tomato, and there was such a public outcry that it actually stopped all research on GM for a decade.
Correct. So we had this focus group, and we asked the parents, because we were not sure, having your child being controlled by technology, it's not obvious that is going to work. And they said, anything. We really need our life back. It is really taking so much of our time. It affects the whole family life. So it was one of the moments where we could see that it's actually something which is needed by people. It's not just that our research is saying we can do it, but it's something which was needed. And the other one is that, so this was quite a defining moment looking back. And the other one was always the weak step was the sensing technology, whether it's good or bad. And then we did lots of simulations, lots of work with computer modeling as well. And we can see, actually, even with these imperfect sensor glucose, we can improve outcomes. We can still do it safely. So it helped us to design controllers, design our clinical studies, to test the system in various situations. So I think it was a gradual steps, and this understanding that the imperfect parts can still create something which is safe and helpful. Because
they often say that perfection is the enemy of the good.
Exactly, and it was exactly the case. People were trying to do things perfectly.
And actually, we do perhaps try to over-engineer sometimes to have, all of the bells and whistles.
Yeah.
And actually, that's where involvement of patients is really, really important, because they will actually tell you what matters.
Exactly, and I think listening, we learn to listen. Sometimes it was in the initial stages, we were driven by what can be done, but I think we always try to listen, and the feedback we receive from the patients on how we changing life has been really extremely motivational.
So we're sitting here in an exhibition hall that is just full of not just one company with CGMs, but all of them, and all sorts of different monitors, and if you'd been in your fever dream going through this hall when you were starting in the 80s, you never would have believed it, really, would you?
Exactly. I think we see explosion of these technology, and I think what we also see is explosion of clinical adoption. And I think these two things are driving together, because it has been proven these technology work. I think we will need to think about it economically, what is going to be viable, because these technology cost money as well, but they save money in long term. money to the healthcare system. I think this is a for me, because I was involved from the very beginning in the research, and it is very unusual where you see your research going from the basic steps where you really think about the concepts until you see the wide adoptions and once in lifetime opportunity or once lifetime achievement. And I'm sort of conscious, and I think me and our group are savoring these moments and still working very hard.
As you should. But let me just take you now a bit beyond, because where do we need to go next? I mean, you've already hinted that it needs to be cheaper. It also needs to be more sustainable, because there's too much throwing away and disposable,
correct,
single use, all those kind of things, which we just can't continue doing. But where are the needs for the future?
Yeah. So there are some immediate needs, and one is that, again, in principle, we can manufacture these technology. But one of the limitations is actually having the healthcare professionals understand how it works, make it available to the patients. So it is really the clinical adoptions. And I think that is lacking because we had a COVID, all the healthcare services has been challenged by resource issue, and now comes a new technology, and some of these technology require for you to know mobile phones, Android system, iOS, how it works, because really we are looking at communications, safe communications, sending the data to the cloud, parents monitoring what's happening to the child, and then if it doesn't work, they go to the diabetes nurse, and so she needs to know. So it is this learning curve for these right now to be able to actually know the technologies and deliver it. So that's the adoption. The other one is the technology itself, how it's going to progress. And I think, as you mentioned, making it cheaper, make it in the way that it will be less intrusive. Alarms are great, but alarms are also bad. One needs to sleep in the night. So all this combination of human factors as well. I think, we are in the stage where the basic technology works, but I think what is needed to make it fit into life.
So it's the human factor design. It is human
factors, which includes also, to be green, not to throw things too much. People are, especially young people, are now concerned about all these aspects. So,
and also I noted that one thing I noted when I was talking to somebody yesterday about the difficulties that young people with diabetes, particularly in ethnic minorities, have in rejection of. And then I'm looking at all of these monitors, and they're all white. And I know that there are some skins that you can put on, but it really does advertise that you have a condition which has a stigma.
And again, something I wanted to mention, it is known that sort of in the use of diabetes technology, which includes all the aspects of insulin pumps, CGMs, there is a socioeconomic divide. So people in lower socioeconomic classes, they will be less exposed to using these technologies. So we have this gap. And I'm afraid, again, one possibility to think, well, if we have a more complicated system, we close the gap. But unfortunately, the truth is the other way around. The gap is increasing. So this is one of the challenges
to simplify systems, to make them accessible and cheap.
Make them accessible, cheap, and for the healthcare professionals having confidence to use them or to give them and to offer them to people with type 1 diabetes.
And Roman, one of the things that must have given you most pleasure is to be at a meeting like this and to hear speaker after speaker after speaker say that because of these devices, the incidence of complications is falling in people who use these devices. So it's not just that you've created something, you and your team have created something which is, made life easier. Actually, it's also reducing complications and helping people live longer.
Indeed, and I think what is especially, we can't see it right now, but what is heartwarming is to see the life expectancy with people with type 1 diabetes going up. I have a slide which basically shows in 1920s it was 1.3 years, something like that, and now it's going to close to what standard expectancy is. I'd like to also add one more population, which is pregnant women with type 1 diabetes. So we done
who are underserved at the moment.
Underserved, and our system is approved for these women. And we had a system, closed loop system, which was called Florence after Florence Nightingale. And I was told that via the clinical studies that there were a number of babies called Florence as well. So it was probably nice.
So Roman Hovorka, it's been an absolute pleasure talking to you. And as you say, it's really quite rare in science that you work on something and see it play out completely in your lifetime. And we are seeing this all around us now is actually the fruits of what you have done over your lifetime. So congratulations on the award. It is a great and signal honour to a great pioneer in diabetes. Thank you so much.
Thank you.
Well, wasn't that fab? It's such a treat talking to Roman. But do you know what? There's lots more to come on EASD TV. See you soon.